Welcome to this lecture of pharmacoepidemiology, where we will address the case control design. Um, in this lecture, I will have two things that I would need to point out in this lecture. First, you will see some slides that are vague or gloomy. These are slides that I decide not to cover. Also, the other thing is I will try through this lecture to revert back to a certain article. Let me see if I can show you the article. Um, this is the article, and it's an example of a case control coming from the British Medical Journal, and the title it's Non-steroidal anti-inflammatory drug use and risk of atrial fibrillation or flutter, population-based case control study. You can look and find this article downloaded if you want. It's available for free on the internet on the BMG. I think it's an open access. What will happen through this lecture is, as I said, you have these slides that I will not go over. Um, you will see that I will refer back to this article, so I'll have excerpts of the article that I will discuss as we go through. So first off, I think it would be a good idea if we go over the abstract of the article just to get an idea of what the article is about, and then we go over the material of the case control design. Okay, so the abstract. The objective is to examine the risk of atrial fibrillation or flutter associated with use of non-selective, non-steroidal anti-inflammatory drug NSAIDs or selective COX-2 inhibitors. The design is a population-based control study using data from medical databases. The setting is northern Denmark, where it's a population of 1.7 million. Participants are 32,000 approximately patients with the first inpatient or outpatient hospital diagnosis of AFib or flutter between 1999 and 2008. 325,000 age-matched and sex-matched controls based on a risk set sampling. All of this will be addressed during the lecture. The main outcome measures exposure to NSAID use at the time of admission or before. Current use was further classified as new use or long-term use. We used conditional logistic regression to compute odds ratios as unbiased estimate of the incidence rate ratio. We'll come back to this being an odds ratio, and it's an estimated of the incidence rate ratio, yani the risk ratio, which we have discussed in the previous chapter, when an odds ratio is a good estimate of a relative risk. The results, 9% of cases and 7% of controls were current users of either NSAIDs or COX-2 inhibitors. Compared with non-use, the incidence rate ratio associated current drug use with AFib or flutter was 1.33, with a confidence interval of 1.26 to 1.4 for the non-selective NSAIDs and 1.5 with a confidence interval of 1.42 to 1.59 for the COX-2 inhibitors. Adjustment for age, sex, and risk factors for AFib and flutter reduced the incidence rate ratio to 1.7 for non-selective NSAIDs and 1.27 for COX-2 inhibitors. So I think this is enough for the article itself. As we're going through the lecture, we'll come back to it. All right, so usually we start off with a section of what are you supposed to already know, because you have seen the case control design in the previous year in PHA 421, and you've heard me mention it when we talked about the measures of associations. So there are things that you already know, and there are things that I would like to explore further. So what do you already know about the case control design? Subjects are selected on the basis of their disease status. So either they have the disease, we call them cases, or they do not have the disease, we call them controls, yani free of the outcome. So they either have مثلا the ADR or not. The two groups then are compared with regard of their history of exposure. It was the perfect solution for studying diseases that have very long latency period. They're good to study rare disease. It's efficient in time and cost. Good to study rare disease or rare occurrence. Also, you should know that the case and the controls are defined based on the status of the disease in question, either present or absent. But for exposure, the researcher can ask about as many exposure as they seem fit. Yani, for example, lung cancer in a healthy individual, then ask them about smoking history, employment, asbestos exposure, genetic factor, environmental factor. Or مثلا you can ask a group of people that have ADR versus those that do not, and you can ask them about the exposure to the medication. You can ask them about exposure to other medication. You can ask them about their history, their health history. Okay. If you have watched the cohort video, then you should note that, just let me draw it real quick. So if you're thinking about the case control, you're starting with cases and controls, and then you can ask about as many exposure as you want, okay, in both the groups. هيدا للcase control. In the cohort design, you're starting off with exposed and not exposed, and as you're following them up, they may develop different outcomes. All right, so that's it. Okay, so here's, for example, define it as either a case or control, like lung cancer versus control, and you can look at exposure one being smoking, employment, asbestos, environmental health, as I mentioned. Um, so let's go back to the article, and I have a question for you. In the article, and I say assigned to reading. I mean, you don't. It's not really assigned, but depending upon the situation that we have, the year you're watching this video. What was the disease and what was the exposure? Dayman, in any study, you've heard me saying this a lot. You're always looking for the independent and independent variable and the population of interest. So if you go back to the article, you have this sentence right there that says this. To address the limitation of the existing literature, we conducted a large population-based case-control study examining whether and to what extent use of NSAID increases the risk of AFib or flutter. So this is establishing the need of the study. It's also pointing out the design used, the outcome and the exposure are identified. So by reading this, you can figure out that the outcome is atrial fibrillation or flutter, and the exposure is so far NSAIDs. Don't worry too much about the PICO. PICO is just the population, the intervention or the exposure, if you write it with the E instead of an I, the control group, what kind of control group you're looking for, and outcome. And this acronym helps when you're searching for a certain literature. Now, I have it here sometimes because I like to help you figure out if you were looking for the study, how would you look for it using the PICO. Anyway, let's continue with the things that you're supposed to already know. Um, Problems with the case control design, assesses exposure and outcome at the same time. Um, يعني how you should know that a case control is a retrospective, meaning you start with the outcome and then you look into the exposure. Therefore, it's susceptible to bias that relates to how the cases and the controls were selected. Careful consideration should be placed when planning case control studies to avoid biases. You've seen the pyramid of evidence, and by now you know that the case control design is a weaker design as compared to the cohort design. وطبعا الcohort design is better than case control, but it's weaker than the RCT. So, generally speaking, case control is more prone to bias than cohort. Also, you cannot establish temporality in case control design because you're not looking at things in the appropriate order. You're not establishing exposure and looking for the outcome. Okay, so these are the things that you already know. Now we need to look at the new aspects of case control design. And these are summarized in the following 6 points. First, how do you go about defining the case? Second, how do you go about selecting the cases? Number three, selection of controls. Four, ascertainment of disease and outcome. And five, ascertainment of exposure. Six, role of bias. Anytime you're reading any article, really, you have to always think about how did they get their sample, whether it's a cohort or an RCT or a case control, or so how did they make sure that every group really belongs in their group? So where did they go to get their sample? If it's a case control, where did they go to get the cases? Where did they go to get the controls? If it's a cohort, where did they go to get the exposed? Where did they go to get the non-exposed? Second thing you need to always ask yourself, the measurement. It's about measurement. How did they make sure that the outcome is present, or the outcome actually is absent? And how did they make sure that the exposure is present or the exposure is absent? Because these things actually will determine how good your results are. And always think about the potential effect of bias and confounding. All right, so we're going to follow this outline point by point, and we'll try to address every point in them. So number one is the definition of a case. Example of importance of a clear definition of a case. In the 40s, cancer of the corpus uteri and cancer of the uterine cervix were both labeled as uterine cancer. The problem is that these two different cancers have different etiology. وهون مربط الفرس as they say. Okay, that's the important thing when you have two diseases that have different etiology, different risk factors. Lumping them together made it practically impossible for epidemiologists, researchers, to find factors associated with the disease. Now they're putting oranges and apples together, and therefore, when you try to look for risk factors, one is washing the effect of the other. For example, it turned out that the first is associated with high socioeconomic factors in contrast to low socioeconomic status for the second one. So it was impossible to find risk factors. The idea is make sure whenever you're doing a case control or reading a case control that there is a clear definition of what a case, and that definition is an accurate one and an acceptable definition of a case. Cases should represent a homogeneous entity of disease. They should meet very clear, specific diagnostic criteria. As I said, if there is some sort of standard you can go back to for the diagnosis criteria, then go back to it and compare. Are they using the standard diagnostic criteria, or are they using a different one? Because that will help you evaluate the study. So diagnostic criteria, مثلا, for myocardial infarction are the following three things. If a study is not using these three criteria, they're only using one of them, then you ask yourself, how good are their definition of the case? One diagnostic criteria are met, we proceed to selection procedures. So here you have a slide that I'm skipping, and we go back to the article. What was the case definition used, and were the selection criteria clearly defined? So let's go to the article and let's read and see what's the question. So somewhere in the article, في a section that is titled Patient with AFib or Flutter. And as you're reading, you reach a point that says, because AFib and flutter share risk factors and to some degree pathophysiology, we collapse them into one disease entity. More than 90% of patients registered with these codes had AFib. So, case definition. Is there reasons to believe that the collapsing of the two entities into one is detrimental? And if so, in which case? And did the author make a point here? What I'm trying to point out here, أول شيء meaning cases. And remember, we said that when you're doing a case control, it should be a clear entity. In this study specifically, they're collapsing two entities. However, I told you that it is important when you're collapsing two entities or when you're identifying a case, an outcome, not to collapse it with another one because they may have different etiology. The authors of this study, they decided to collapse both, okay, and they tried to defend their point. So they did something that نحن usually we're not in favor of. Usually we do not like when people put two diseases together. However, how did they define their point? Well, what they said is that in the case the two diseases have different etiology, collapsing them would make it difficult to find any association. The authors tried to make for it by saying that they share risk factors and pathology. So عم يقولوا لنا that AFib and flutter have the same pathology and risk factor, and therefore putting them together is not a big deal. However, I still have an issue with that, is that they said that out of all the cases, 90% are AFib and only 10% are flutter. So my question is, why to include flutter? Why don't you just go with AFib? Make a study about AFib without flutter. Why did you need to collapse flutter? Anyway, that was their choice. Let's continue with our lecture. Number two in our lecture is case selection. Where do you go to get the cases? Where do you go to get people that have the outcome? So you think about the source and you think about the type of cases. So the source could be either a population based, yani you're going to get your cases from the population, or usually hospital cases. And the type of cases, they can either be new cases, incident cases, versus prevalent cases. Okay, and you know the definition and you know the difference between the two, and you know the implication of incidence versus prevalence. So identifying patients with a specific diagnostic criteria within a specific period of time. You need to find them. There are several possible sources of cases. You can go to the population مثل ما قلنا, or you can go to hospital, clinics, or medical centers where you can find your cases. حتى مثلا registries, you can find your cases in registries. Should consider inclusion and exclusion criteria like any other study and the impact of these criteria on the generalizability of the results. طبعا كل وحدة بين هول الاثنين has its advantage and disadvantage. Alright, so continuing with case selection. In theory, cases should be a representative sample of all cases. This is what you try to aim for as a researcher. I want to get cases that are representative of all cases. Because if you end up getting part of the cases, you have obviously something called selection bias, and therefore you cannot generalize your results to the entire population. However, even if your cases are not representative of all cases, the case control study is still valid. So it may still have internal validity, but its external validity might be at problem. Population-based involve locating all cases in a community than taking a random sample. It is harder, but the cases are more likely to be representative. If you are able to find all the cases within a population and taking a random sample, that would be perfect. How do you think this is possible? How do you think you're able to find all the cases? If you think about it, this is possible if there is some sort of a data collection system. Yani specifically, مثلا, if you think about a situation where you have some sort of coverage, health coverage, and you can go to the records and find them, which takes us back to the idea of using a secondary database. And therefore, you can think about whatever we discussed in that chapter. The other type of cases in the hospital base, it's easy, it's convenient. You identify cases from medical center or hospital or clinics. When used, it's crucial that you have a thorough understanding of the process involved in having people going to that center or clinic. يعني if you're picking a center that is mainly visited by a higher socioeconomic status, you have to understand that. If you're picking up مثلا a hospital that is very well known for its doctors that are specializing in kidney, then you have to take that into consideration as well. So you need to understand meaningful cases that you are coming to that specific center, whether it's their history of the illness or whether it's socioeconomic status or their education, or you need to understand that, so that because that will allow you to understand their background information, which at the same time has to be taken into account when you're going to select controls, and we'll get to that in a minute. So diagnostic tools and tests may have been already done, and thus validation of the case is easily done. Obviously, if you're going to a hospital to get your cases, probably all the things that are done at the lab level are already done, and therefore you could be pretty much sure of that case that is the case, especially if it's part of your diagnostic criteria. So do we pick incident cases or do we pick prevalent cases? Yani the major difference between incident cases, prevalent cases, incident cases allow you to estimate risk and incidence rate. Whereas prevalent cases in not only cases that have the disease, but also they had it for a while, which also may have developed other problems and things. For rare diseases, you may have to take prevalent cases to have enough load of patients. Prevalent cases reflect the presence of the disease as well as the duration of the disease and the complication that comes with the disease, and thus its complicated results. Prevalent cases will miss those that died or that were cured. Ama incident cases, you got them fresh enough that if unfortunately this outcome kills people, then you're capturing them early enough so that they don't die. Or if this outcome is not that serious and people they get cure from it, then you capture them early enough that they are still um, diseased. So again, I have more details that I'm not gonna go over. Just let's go directly to the article. So cases in the study were incident or prevalent. This is question number one. Were they population based or hospital based? Question number two. And was the disease rare or common? All right. So if you go and you start looking at the setting, there is a sentence right there that says, we conducted this population-based case control study in northern Denmark. So here you go. That's your first answer. It's a population-based. And since 1998, complete computerized prescription records have been available for this population. Um, so if you think about it, ليه عم يقلنا إنه there is a complete prescription records for that population. هلا we'll come to that in a minute. We use the Danish National Registry of Patients. So this is under patients with AFib and flutter. So this is where they tell you where did they go to get their cases. So under registry, as easy as this, they have a registry, which is the Danish National Registry, covering all non-psychiatric hospitals since 1977. يعني كل الhospitals من 1977 emergency room etc. If they have an AFib or flutter, they will register that case in that registry. Okay, and emergency room and outpatient visits since 1997 to identify all patients with a first-time inpatient or outpatient diagnosis of atrial fibrillation, yani AFib or flutter during the study period. So they're telling us in specific details where did they go to get their cases. So question number one قلت لكم ليه عم يقلنا في complete prescription records. This is probably we're going to go back to that in a minute. لما حنحكي على measuring of the exposure. The author trying to establish that the registry is complete and that cases are representative. Okay. عم يخبرنا كل هالخبرية ليقلنا إنه إذا في حدا صار معه AFib ولا flutter, there is no reason that person is not showing in my registry in where I looked for cases. So they're saying that any AFib case will be there, and therefore this is a population based. To some extent, to a certain to some extent, the ascertainment of outcomes since the diagnosis was done at the hospital, so we have some level of trust in the result. Come in. So not only we're capturing all the cases, but these cases were captured through hospitals or emergency rooms or outpatient clinics. So they were captured through a valid mechanism and they were put in a registry. And therefore, when I go and I get them, I'm getting a clean case, a case that I can trust. And it is تقريبا the registry have all the cases, therefore it's a population based. So what about the controls? Where do I get the controls and how do I get the controls? Selection of control group should reflect on the selection of the cases. What we mean by that is the following. The selected control should be selected so that they present the group of people that would have been selected as cases if they had the disease. الفكرة هي التالية. You do not engage a selection procedures for the control that will lead you systematically a different population than the cases in terms of their exposure status. Okay, يعني you have to make sure that the controls represent as much as possible what would have been a case and expect that they are not cases. Okay. يعني أنا ما بروح بجيب my cases in a hospital, private clinic that is very expensive and only people that have high insurance, مثلا private insurance that can get into that clinic. And when I want to go get the controls, I get them from the public hospitals. Automatically they're going to be different with regard to socioeconomic status. ما فيك تقول ساعتها socioeconomic status is a risk factor for the outcome. لا. You selected them that way. You forced a difference between the cases and the controls. And therefore you try to limit that by trying to replicate the selection procedures for the cases. However, uh, they have to be controls, not cases. So where do we go and get the controls? في hospitals, في general population, وفي special groups يعني هن friends, neighbors, relative of the cases. Also, we need to talk about the ratio of controls to cases, كمان the matching. في concept utilized a lot in case control, which is matching. So, regarding hospital controls are selected from the same hospital where the cases were selected. Okay, this is very important. As I said earlier on, as I'm جيب cases من very high end hospital that is very expensive, very hard to get to. Your controls have to be from that same hospital. So, example, cases of myocardial infarction were selected from the coronary care unit of a hospital. Controls were selected from the surgical, orthopedic, and medical services units of the same hospital. They had musculoskeletal and abdominal diseases, among other diseases, but not coronary disease. It's totally fine. Controls, by the way, they do not have to be healthy. All what is important is that they do not have the outcome of interest. Okay. بس بدكم تنتبهوا انه ما يكون معه disease that share same risk factors than the actual outcome. So what are the advantages of hospital controls? They are easy to get, minimum effort and resources. They will minimize something called recall bias. وهلا بنحكي على recall bias. They will minimize selection bias since they came to the same hospital, then they must have been exposed to the same underlying selection procedures that people go through in selecting a hospital. They reduce also the non-response bias. They're more likely to participate. The disadvantage of hospital control, hospitalized control may have diseases that might share with the case some exposure factor. هذا اللي كنت عم لكم a minute ago. So for the example, hospitalized individuals are more likely to be smoker than the general population. Thus, comparing the CHD cases to controls from the hospital will fail to show association of smoking to CHD. Okay, so that's an issue of controls from hospitals. Again, skipping this slide, general population controls. Those are controls selected from the community. This is the selection of choice if cases were representative of the community. So if your cases are representative of the community, they are representative يعني of all cases, then your controls for also should be representative of all controls, yani they should be coming from the community at large. The method of selection, you can go to neighborhoods to select your controls. You can use the random digits telephone dialing to dial randomly people and try to recruit them in your case control study. Voting lists can be used to identify and select controls. Any type of methodology where you can get your community at large to be served as controls from the general population, that will be fine. Akid, when you're going to the population in general and getting your control, you have to think about how do I make sure that they do not have the outcome. What if your disease is silent disease مثل hypertension ولا مثل diabetes? Going and selecting someone from the population and asking them, do you have diabetes? Be like, لا. What if they do and they don't know? What should you do to make sure that they don't? So the disadvantage of the general population control is that it's costly and time consuming. You have the issue of recall bias. Controls may not remember past exposure with the same precision as the cases. Maybe at a later point نحكي عن recall bias specifically. controls from the general population and on lower response rate. Refusal to participate are usually different from those who do participate, resulting كمان in more bias. And therefore, if you're reading an article that is a case control, طلعوا على ال participation rate or refusal to participate, try to figure out was it within acceptable limit. Not to mention that tests may be required to make sure that they're not false negative. As I mentioned هلا قبل شوي, like, do we run a blood test for these controls to make sure that they're not diabetic? Do we ask them to do some sort of testing, etc.? That will come in accrue on the cost and on the difficulties and حتى on recruiting. يمكن حدا يقول لك ايه I want to participate, تيجي بتقول له بدي اخذ blood sample, they would say no, forget it, I don't want to participate anymore. Alright, بعد في one type of control group يلي هن special groups, هن relatives of the cases, friends, spouses, neighbors. A very specific case control بيكون حدا معه a certain disease بياخدوا التوين إذا عنده twin as control. The obvious advantage when you're doing twin studies is that that twin share the exact same genetic factor as the case. And heck, you're ruling out the possibility or the role of genes. The advantage of taking special groups is they're more likely to participate, is that you know that your friend is being selected in a case control study, and your friend is a case, and you're asked to be part of the study as well as a control. You're probably more likely to accept to participate. They control for extraneous various factors, مثل socioeconomic, مثل ethnic, مثل education, because relatives بيشبهوا بعضهم, friends بيشبهوا بعضهم, spouses بيشبهوا بعضهم, neighbors بيشبهوا بعضهم in terms of their socioeconomic status, in terms of their education, in terms of many things, and therefore you're getting controls that are not inherently different than your cases with regard to these things. The disadvantage, they might share same lifestyle habits as cases, and as such, you can no longer compare with regard to a certain outcome. إذا مثلا your cases, you're interested to know if the cases مثلا um, let's say you're looking at their drinking habits. You want to see if there is an association with alcohol consumption and the side effects that you are studying. If you pick somebody who's a friend or a spouse or relative, they probably بيشبهون in terms of drinking and amount of drinking and the type of drinking, and therefore you can no longer explore if drinking alcohol and the type of and the amount might be related to side effect. Which takes us to an interesting point, يلي هو the ratio of controls to cases or case to control. How many controls should we recruit per case? Maybe the first thing that comes to mind is 1-to-1. You take one case, one control. However, if you go more than one control per case, then they could be drawn from different sources. كنا من شوية بنقول إنه عندكم controls that are hospital based, community based, special group based. كل واحد عنده الادvantage with disadvantage. You may, for every control, pick one. For every case, pick one control that is from the hospital, one control that is from the community at large, and one control that is from a special group. هيك بتكونوا you're getting different controls with the different advantages of every one of them. So as I said, if more than one control per case, then they could be drawn from different sources, different diagnoses. Even some can be from hospital, other from special groups, while others from general community. So the example, pancreatic cancer case control study, the controls from hospital were good in many aspects, but not to assess coffee consumption. منشان هيك community control were also used to be able to address this concern. So يكون عندك different controls, وكل control has its own advantage, and you can utilize that to the advantage of your study. So how many controls per case? So do I get 2 controls, 3 controls, 4 controls? While issues of resources, availability of controls are important, it should be noted that it's not recommended to go beyond 4-to-1 ratio. يعني recommendations بيقولوا إذا بدك تاخد more than one control, don't go beyond 4. ليش they say don't go beyond 4? Because the power gained in increasing the ratio of controls to cases reaches a plateau at 4-to-1. هون لما عم أقول power, I'm talking about power of what? Power of the study. Okay, remember, every study has a power, and the definition of the power is the probability of the study detecting an association if an association really exists. The power of the study is directly linked to sample size. كل sample size is larger, the study has more power. Therefore, if you limit it by your number of cases, then the total number of cases you can get for a certain, let's say, side effects, مثلا بنطلع those that pass out. The number is small. You're not able to get more than 22. If you get 22 controls, your sample size is 44, and that limits your power. If you want to increase your power, you want to increase your sample size. You can only increase your sample size in that situation by increasing the controls, getting more controls. And therefore, instead of getting 22 controls, you can get 44 controls, 66 controls, or 88 controls, all the way up to 4 times. طب ليه مش 5 times 6 times؟ لأنه the power will reach a plateau. يعني at one point in time, you will no longer gain from power. And I'm gonna skip this, which talks about matching. I'm just gonna go directly to this one, and this is exactly what I was talking about. So this is coming from a publication, and it's statistical power and case and controls per case. So on the x-axis, you have the control per cases. So do I get 1 control per case, 2 controls per case, 3, 4, 5, all the way up to 10 control per case? On your y-axis, you have your power, okay? And the lines are showing what happens to power as the number of controls increases, number of control per case, okay? And the different lines are representing different prevalence of exposure in the controls. The point being, they're all showing the same trend. From 1 to 4 تقريبا, you have kind of like a real increase in power. You're really benefiting a lot from getting more controls. But once you hit this 4, okay, the line is still going up, but not that much anymore. So the effort, the time, the expense that you're putting on getting one additional control per case is not really getting you that much power. So لما قلت أنا the power is gain is عم يعمل plateau, this is what I'm saying. The line after 4, okay, starts to it's in increment. I'm looking for the word. Its slope is no longer as strong as it was from 1 to 4. 1 to 4, you have kind of like a much faster increase in power, and it slows down after 4. Okay, so number 4, that's where the number 4 is coming from. It's coming from, say, a statistical simulation like these that say that you're not going to gain that much after 4. So let me go back one slide, the one that I skipped, اللي هي كانت the matched case control. شو معناتها matched? One or more controls are matched to case based on pertinent variables such as confounder. It increases the accuracy and the statistical power. شو معناتها كل هالحكي؟ So أنا عندي case. He's a male. بجيب control who's also a male. ساعتها بقول the case and the controls are matched by gender. So as the case turns out to be a female, I will get that female a control that is also a female. Okay, so I try to match my cases I try to match my controls to my cases based on gender. وبنقول في matched based on gender. If you also add to that age, so the first case was a male and he was in his 50s, you try to find a control who is also a male in his 50s, then you're also matching by age. So بتصير بنقول we're matching by age and gender. And the idea behind that is that you're reducing the effect of age and gender as potential confounders. Okay, if you suspect that age is a confounder, one way you can deal with that is by matching your cases and your controls by age. If you suspect that gender is a confounder, you can limit its effect by matching according to gender. So when you match, it increases the accuracy كمان the statistical power also increases. Method to determine the appropriate number of matched controls suggested by Hansi et al. So this is the lines that I showed you, and so this is what we talked about. Let's continue. So if we go back to the article, I have the following questions for you. What was the type of controls used? How many controls per cases did they select? What is your opinion about that? Was there a matching done? So بدنا نسأل controls من وين اجوا؟ شو كان الريشيو of controls to cases؟ وكان في matching ولا لا؟ So let's read and see if we can find the answer to that. So under population controls, this is where they're going to tell us where they got the controls, and you can see like it's given population controls. We use the Danish civil registration system to select 10 population controls for each case, matched for age and sex. This registry has recorded vital statistics for the Danish population since 1968 with daily updates. We selected controls using the risk set sampling. Okay, so I hope by reading this paragraph now you can answer the type of controls. Obviously, they were population and on a registry that has everybody in there. So everybody is there. You can get your controls, their population. The advantage of the population is that you can calculate something. Remember, we said you can estimate is that your cases are incident cases and your controls are good controls represented the population. في كنت بلشوا تعملوا شيء اسمه you can estimate your the risk. Was there matching? Actually, yes, and they do say that, saying matched for age and sex. What do you make of the numbers? So how many controls per case? They got 10 controls per case. نحن قلنا do not go more than 4. And they went all the way up to 10, which is too much. But I mean, if they're willing to do so, it's not like it becomes bad. It's just you're not gaining too much power out of it. That's it. It's just, I mean, it's your resources, your time, your effort. However, the last thing they talk about is they say that the controls were selected using something called the risk set sampling, which is something that we did not discuss. I will talk about it very briefly. The answer to these questions are here. Population-based control, meaning that controls were from the general population, which is the best type of controls when cases are from the population as well. Matching was done based on age and sex. Age and sex cannot be studied anymore. Remember, once you match for a certain variable, you cannot assess it as a possible exposure anymore. Risk set sampling controls are identified from a pool of controls that were available when the case became a case. شو معناتها هالحكي؟ You have the answer here. So think about people passing through time, and as people are passing through time, when they get the X يعني they get the outcome. So هول ال X هن اللي صار عندهم outcome واللي ما عندهم X ما عندهم outcome. So you come into the calendar time. So let's say this case became a case in 2002. So you pick that same date and you look at everybody who was not a case in 2002, and from all these individuals you take at random a control. قلنا a control by definition هو حدا ما عنده outcome. So in that specific year كل حدا ما كان عنده outcome, you pick it to be a control, knowing that هذا الشخص هون was a control in 2002 مثلا, yet that person is going to become a case 5 years down the road. So even though that person is going to become a case five years down the road, that person may be serving as a control in 2002 for that case. That is what is called a risk set sampling. I do not know much more about it, so if you're interested in understanding the advantages and disadvantage, you're welcome to do a search and share what you find with us. That takes us to number 4. Okay, so لكن حكينا the definition of case. We talked about where do you go to get your cases, hospital ولا community, are they incidents, are they prevalence, where do you go to get your controls, population ولا special group ولا hospital, rate of controls per case, do you match or not, Now we need to talk about how do you ascertain your outcome and how do you ascertain your exposure. So we're starting first with how do you ascertain your outcome. How did the researcher go about confirming the outcome, the diagnosis? What diagnostic tool was it used? What test did they use? Are the method used to recognize established diagnostic criteria? Are the validity, the sensitivity, the specificity of these tools known or not? These are all valid questions that you can ask when you're evaluating a study, a case control study. So ascertainment of outcome continued confirming the case. Lung cancer, مثلا, is confirmed with a biopsy. Arteriosclerosis is confirmed with an ultrasound of the carotid arteries. Osteoporosis is confirmed by bone mineral density. So confirming the case will impact the misclassification that we will discuss later. You probably have heard this term before, misclassification, and it's as simple as the term means you're misclassifying an individual, either with regard to their outcome or with regard to their exposure. So when you misclassify with regard to the outcome, so you had a case and you miss that and you think that person is control, or she's a control and you're misclassifying her as a case. All right, so this is with regard to the outcome. With regard to the exposure, this person is actually taking the specific medication you're interested in as an exposure. However, you missed that and you're thinking that they are not taking. والعكس صحيح. So this is the misclassification. So again, I'm skipping a few slides. So in the article, how did they ascertain the outcome? That a case is a case and the control is a control. Let's again look at the example and see what they say. They say the Danish National Health Service provides universal tax-supported healthcare, guaranteeing unfettered access to general practitioners and hospitals and partial reimbursement for prescribed medications, including NSAIDs. Most patients with atrial fibrillation or flutter are diagnosed during a hospital admission or hospital outpatient clinics. Very few cardiologists work outside the public hospital system in Denmark. Okay? So if you're reading this, لازم براسكم تكونوا عم تسألوا all this information means what to me. So the author trying to establish that the registry is complete and thus cases are representative. عم يقولوا لكم إنه إذا حدا عنده unsaid, that person will be part of my registry. لأنه these are diagnosed at hospitals أو at clinics وهول الكلينكس are part of my system and therefore they will appear. طب everybody can go? Yes. ليش؟ لأنه everybody is insured. To some extent, to ascertain the ascertainment of exposure, since the diagnosis was done at the hospital, so we have some level of trust in the result. Okay, so we feel very comfortable about this article, and when it comes to ascertainment of the outcome, إنه نعرف إذا حدا عنده unsaid ولا لا. We feel very comfortable that using their registry, which is a secondary database, those that turn out to be cases, we feel very comfortable that they actually have the cases, and we also feel comfortable إنه إذا في حدا that has the outcome, they will probably be captured by the system, and therefore we don't think that we're missing anyone. Ascertainment of exposure, procedures followed to ascertain the presence or the absence of the exposure. Exposure could have happened in the past. This is why case control are considered retrospective in nature, right? I mean, you start with the outcome and then you start asking about what happened in the past. Essential to establish that the exposure occurred before the occurrence of the outcome. يعني كتير مهم إذا عم نيجي نعمل case control ويكون عندنا prevalent case، حدا صار له زمان عنده الأوتكم 5 years مثلا with high blood pressure. When we ask a question about utilizing certain medication ما يكون بلش الميديكيشن بعد ما صار معه high blood pressure. Okay, لازم يكون قبل. Which also point out the importance of having incident cases in a case control لأنه هول ما لحق الوقت to pass. So if they're taking the medication, most probably they have been taking the medication before the outcome occurred. Ascertainment of exposure should done at the same rate for cases and controls. You've heard this probably in other designs, the methods, the intensity, the effort put in ascertaining whether the outcome ولا the exposure. هلا هون we're doing it for exposure لأنه it's a case control design. In a cohort, the effort you put in ascertaining the outcome, it has to be at the same intensity for both groups. You should not give special attention to one group versus the other group. Okay. And the cohort design أعطينا الexample إذا عندي حدا عم ياخد blood thinner versus حدا ما عندي بياخد blood thinner and I'm looking at bleeding, then it should be at the same intensity. هون in a case control بعرف إنه هذا الشخص مثلا has hypertension وهذا الشخص ما عنده hypertension. The way I'm gonna ask about their utilization of medication, it has to be the same way, same exact way. Yet you can blind. If you can blind with regard to outcome, it would be perfect. So when possible, use a valid tool for assessing the exposure. When exposure can be done using a test, a blood test, check the sensitivity and the specificity of the test used. Sensitivity and specificity, if you've forgotten شو معناتها sensitivity and specificity, so you've seen these terms in public health. Sensitivity is the out of everybody that has the disease, a dish will be positive. With specificity, out of everybody who's healthy, a dish the test will be negative. يعني كمان a quick reminder. If I'm looking at لنقول a group of patients, so I'm testing a group of individuals. So whole actually they do have مثلا the COVID-19 and whole are healthy. فكرت حالي غيرت اللون. Whole are healthy. Okay. So if I have 100 COVID-19 and out of the 100 those that test positive هني 99 and one test negative, منقول sensitivity is 99%. This is sensitivity. Out of everybody who actually has the disease, how many tested positive? This is sensitivity. And out of the healthy, let's say كمان you start with 100 healthy, and out of the healthy مثلا نقول 4 tested positive and 96 tested negative, we say that this test, the specificity is 96%. So 96% specificity, meaning out of everybody who's healthy, how many actually tested negative. Okay, so that's sensitivity and specificity of certain diagnostic criteria or a test. Okay, so ascertaining of exposure, if we go back to the article, how did the author ascertain the exposure of the cases and controls, and was it done in the same method? So again, if you read your article, فيها section اسمها Non-steroidal and anti-inflammatory drug use, and this is the exposure. And typically that's how an article is written. هيقولوا لكم من وين جابوا الcases, من وين جابوا controls, how did they look at the presence or absence of the outcome, etc. So all the elements that we're discussing, they're actually elements of the article. So the paragraph reads, we use the prescription database in the region to identify prospectively all prescriptions of NSAID redeemed by cases and controls before their index date. وهلا بشرح شو معناتها index date. Except for ibuprofen in the 200 milligram tablet dose, all non-aspirin NSAIDs are available by prescription only. Regular users of ibuprofen typically are registered in the database because the cost automatically is partially funded when the drug is prescribed by a doctor. Okay. So what they're saying is, if you are somebody who is exposed, and I'm نحكي عن exposure, يعني you're taking NSAIDs, you have no reasons not to be in the registry form. Why? Because ما بينعطى إلا بprescription, وإذا انعطى prescription it will be covered. Oops, I'm sorry. So everybody who is taking the medication will be appearing, with the exception they talk about the ibuprofen. Okay, all right, and then they say we identify prescription for non-aspirin, non-selective NSAIDs, so ibuprofen, Naxopro, etc. Older COX-2 inhibitors, and the newer COX-2 inhibitors. Because of overlapping COX-2 selectivity, we collapsed the group of older and new COX-2 inhibitors in one group. So let's continue to see what I have as comments here. I'm sorry, let's go back and read the question. So, what is this paragraph about? What is your assessment of these procedures? What was the exposure? What do you think about collapsing the old COX-2 and the new COX-2? Let's see if I get the answers. This is about ascertaining of the exposure in both cases and control, and the authors are doing their best to show completeness of the information. Okay? They're trying to tell us that we're doing a very good job. في كلمة كتير مهمة, and it's the prospectively. This is a very important question, because it means that the exposure had to had happened before the diagnosis. Okay, or what is called كمان in index date. So شو معناتها index date? Index date is the date where a case became a case. وبما أنه الcontrols are matched to the cases using the risk set methodology, then this index date للcase applies for the match controls. Okay, so إذا أنا عندي case that became a case بال 2000 April 2002, so that's the index date of the case. So I have to make sure that the drugs that they were taking, يعني الNSAIDs, they took it before April 2002. That's for the case. طب for the control ما عنده outcome. So بما انه they're matched by ACE, يعني every case is matched to 10 controls. هول 10 controls, their index date is the same as the case, يعني April 2002. And if they were taking the medications, it has to have happened before April 2002. Okay? All right, now, so the exposure is NSAID and COX-2. All the new collapse could be problematic if the new is not a risk factor. Let's continue. Some side effects may arise shortly after starting treatment, and an inclusion of long-term users who are more likely to tolerate the drug could lead to underestimation of the association with AFib or flutter. We therefore categorized current users into two groups: the new user, defined by having redeemed their first ever prescription within 60 days before the index date, and long-term users, defined by having redeemed their first prescription more than 60 days before the index date. We defined people who had redeemed their most recent prescription 61 to 300 days before the index date as recent users. We defined people with no redeemed prescription as non-users. So basically عم بيعطوكم definitions of the users, يعني exposure, وفاتوا بتفاصيل. So في عنا non-users وفي عنا let me try to find the first ever let me secondly therefore categorize current users. So current users أصيموهن ل new users, and define having redeemed people who had redeemed most before current recent users. So new, recent ونيو وفي عنا non-users. يعني anyway عم بفوتوا بالتفاصيل. Let me try and find the answer to that, which is right here. So عنا current users and users that took the drug 60 days before the index date. Recent users, these took the drug 60 to 365 days before the index date. The point made for stopping taking drug due to side effect is a good point. Someone with side effects would stop taking the drug, and thus when we look at 365, that person would have stopped taking the drug. Those would have and should have developed the disease but did not, and thus weaken the measures of association. 60 days, I'm not sure if this is period is appropriate. It will depend on the time it takes for the effect to occur. 365 days for non-users. Why not stick to never users as non-users? The reason is given by the authors about the long-term users. Do not include those that would stop, but still the question remains, why not only look at current 60 days and forget about recent? Anyway, long story short, they did ascertain the exposure وحتى فاتوا بالتفاصيل, making sure ان exposure occurred قبل الانdex date, وحتى صاروا يفكروا بانه what if صار في side effects, how would that impact the results. So بما انه في side effects بلشوا يطلعوا على current users و recent users و etc. ليشوفوا الفرق بيناتهم, and they explain all of this. Patient characteristics, if we continue, we obtained like an ALO data from the Danish National Registry of Patients on any previous hospital diagnosis since 1977 of disease that may increase the risk of AFib and flutter to increase the sensitivity of the diagnosis. So identifying any other exposure that may increase the risk of outcome, what do they think? Increasing sensitivity, what is that and why? And do you agree? Let's see if we can find the answer to these questions. They are trying to limit the impact of confounder. Okay, so sensitivity is the capacity of detecting مثل ما شرحت لكم إياها by looking at other prescription that ought be given to someone with AFib or flutter. The chance of capturing cases increases, i.e. the sensitivity increase, but wouldn't that increase the chance of capture those that used NSAID and COX-2 and hence increase the chance of finding cases that are exposed? And I'm asking more questions than I'm giving you answers. مهم. That takes us to the number 6 of our outline اللي هو role of bias in the case control designs. So لكن عندنا selection of bias, selection bias I mean non-response. By the way, generally speaking, there are two family of biases. في عندنا bias that has to do with how you selected your cases اسمها selection bias, وفي عندكم bias that has to do with information. So هن طبعا في are many other types of bias, but like the two major types of bias that whenever you're doing anything in research you read about هن selection bias and information bias. So selection bias, non-response bias, observation bias, تحت non-observation bias and the recall bias and misclassification bias. So selection bias. This bias occurs if the selection of cases or control is dependent on their exposure. يعني لأنه حدا exposed عم نقيك case. The example comes from the pap smear study, looking at the relation between the test and the reduction in mortality rate of cervical cancer. Controls were identified through household survey. To be able to recruit one control, the investigator had to approach 12 households. The main reason was that most of the time there was no one at home. Suppose a woman not at home was employed, and as such, she is required to have a pap smear. In this case, this control selected in study are most likely unemployed, and thus underrepresent the pap smear prevalence in the community. I don't know if they وضح example. Okay, so عم ياخذوا case control and the controls هن يلي ما عندهم cervical cancer. They went to the community to get them. The best way is to get the community, and if you have a good representation of the community, that would be wonderful. However, they kind of like maybe underrepresented employed women and overrepresented non-employed women, which automatically means that in your control you have a lower representation of the working women, which would be taking the pap smear at a higher rate than the non-working women, and therefore you're picking controls that have a lower rate of pap smear, and therefore you're going to end up with cases with a higher rate of pap smear and controls with a lower rate of pap smear, and you're going to conclude that the pap smear is related to cervical cancer, but in reality it's not. It's just how you went about selecting your cases and your controls, and therefore leading to selection bias. The non-response bias, this occurs when those that decide not to participate are different from those that participate. So في عندنا شيء اسمه testing for the bias. You compare those that are easy to get to those that were hard to get. Or you can compare the non-respondent to the respondent if possible. How do you compare the non-respondent? If you have data on the non-respondent, مثلا عندنا data على general population, you can compare your cases to the non-population in terms of general characteristics. أو مثلا when you were trying to recruit the controls أو the cases اللي عم يقولوا لا we don't want to participate, if you're able to get just too few information like their age and gender, if they're willing to give you that, then you can use that to compare them to those that accepted to participate. أو في عنا دايما a group of people that ببلش ما بده, and then as you try to convince them بيقبلوا, so maybe you have to contact them first time, second time, third time, and you end up recruiting them after like multiple attempts. هول الصعبين to recruit, they resemble more those that you were not able to recruit, and therefore you can use them as representative of those that they refuse to recruit, and by comparing them to those that were easy to recruit, you can figure out how much you're running into a non-response bias. Observational bias في عنا two major types عنا recall bias و misclassification. Recall bias هتسمعوا عنها basically in case control design, because this is where the cases and the controls do not remember their exposure status at the same rate. Cases are more likely to remember their exposure than the controls. And obviously the example the typical example is the prenatal X-ray exposure and the infant deaths. Mother that had an infant dying will remember her exposure to an X-ray or مثلا taking a medication much more than women that have a normal child without any problem. Okay, so if a woman had our birth defect for that matter, that woman, uh, she will be marked, and therefore everything in her pregnancy will be marked in her memory, and she will be able to remember all the details of her pregnancy, versus a woman that had a normal child, nothing was out of the ordinary. So if you come and you do a case control and you start to ask the mother to recall what kind of medication, she might not recall, and therefore you end up having cases that recall better and therefore a higher rate of exposure, not because عن جد it's a higher rate in the cases than in the control, it's because you just remember it better. And the controls, they're not remembering it as good as in the cases, and then you have an underrepresentation of the exposure in the control, leading to an association which is not real association. The other example of observational bias is a misclassification. And misclassification is, as I've mentioned before, is when you're making an error with regard to disease status or exposure status. And it can happen in either differentially or non-differentially. Okay? So misclassification is if it's occurring at the same rate in both the groups, then we talk about being being non-differential. And the example here we have hypertension and stroke. If hypertension was not correctly reported in 10% of the cases and 10% of the controls, then the misclassification is non-differential. يعني الغلط اللي عم تغلطه at the same rate in cases and in controls. If the rate were 25 and 10%, then the misclassification becomes differential. يعني عم تغلط in one group more than the other group, and that would have a different impact on your measures of association. دايما non-differential will always bias the odds ratio or the relative risk towards 1. In such case, the observed association could not be spurious. Whereas differential can either bias towards the odds ratio, whereas in the case of a differential misclassification, it can either bias the odds ratio or relative risk towards or away from the null. So again, I hope you remember that whether you're calculating a relative risk or an odds ratio or a prevalent rate ratio or what have you, you remember that you start with 0 and you're going all the way up to a very large number. Your reference point is 1. According to the null hypothesis, there is no difference. So this is where the null hypothesis stands, saying that there is no difference, is saying that the odds ratio is equal to 1. So if your odds ratio, the real one, the unbiased, is either on this side or on that side, when you bias it towards the null, you bring it towards 1. So you're making it appear weaker. And this is the effect caused by a misclassification that is non-differential. Okay. So I have an example prepared on Excel. Let's go and look at it. Okay. So right on the top, I have the set of a case controls and about 400 cases, 800 controls. So the ratio is 2 to 1. And I'm looking at exposed and not exposed. And if you do the odds ratio correctly, it came out to be 2.69. This is the real one. بعدني ما عملت misclassification. Next, I'm going to start doing misclassification. However, it's a non-differential misclassification. The first example of non-differential misclassification is cases to controls. So, في ناس that ought to be cases, however, I missed them. So my diagnostic criteria is not good. And I'm missing 15% of my cases thinking that they are controls. However, since it's not differential, I'm going to make the same rate of error in the exposed and the not exposed. يعني حشيل 15% من هون حطهم هون و 15% من هون حطهم هون. okay. So you remove 15% بدل ما 220 بيصير عندنا 187, and the 13 that we removed we put them here. مش 13, I'm sorry, the 33. They're here, and also I'm going to make 15% of 180. I remove them from the 180. I'm left with 157. I put them here. بيصير عندي 577. Okay, you will notice that the total is no longer 400, it's 340, and the controls are no longer 800, they're 160. However, the exposures total بعدهم هن زيتون. That odds ratio, بما انه it's a non-differential misclassification, will be biased towards the null. بما انه the real odds ratio is 2.69, it's above 1, biasing it towards the null, and you're going to bring it downwards towards the null, and it will appear weaker. And sure enough, it appears to be 2.49 weaker than 2.69. We continue with the example. This time I'm going to do كمان in non-differential whole. كلهم whole under this category here, they're non-differential. But this time I'm still making a non-differential with regard to the outcome مثل ما فوق. However, control to cases. So عم بغلط من الcontrols عم حطهم بالcases. يعني I'm over-diagnosing people although they're not cases. So I'm going to remove 10% of the original number. Okay, just let me do this. Okay. All right. So this is the example. So هلا عم شيل 10% من الكنترول. So 10% of 250 is 25. I'm putting it here. بصير عندي 225 ب 245. كمان I'm removing 10% of 550 يعني 55%. 55 I mean, sorry. I'm حطهم بال 180. So you can see how the numbers have changed. Okay. When you calculate the odds ratio, it comes out to be equal to 2.29. Again, the odds ratio has been biased towards the null. It's appearing to be weaker than its real value. Continuing with non-differential misclassification, هلا the example is I'm making a non-differential misclassification with regard to the exposure. So ناس that are exposed, I'm حطهم non-exposed. The rate is 5%. So هولي حشيل من top 5% وححطهم تحت. بس بما انه it's non-differential يعني 5% من الcases و 5% من الcontrols. Okay, so removing 5% من الcases, I'd have to remove 20. I think yeah. So I'm removing 11 وعم حطهم تحت. So بدل ما يكون عندي 180 عم يصير عندي 191. وعم removing from 250 I think it's 12 وعم حطهم تحت عم يصير 563. هلا if you're wondering ليش this عم بعمل rounding هون. I did some rounding حتى ما يبلوا numbers with comma. بس I'm using the formula يعني if you click here you can see that I'm using a formula. And by the way, I think I'm going to put this command on Blackboard so you can actually come in and change that percentage and see what happens. Okay, so by misclassifying 5% non-differentially لتحت, كمان you calculate your odds ratio, and your odds ratio comes out to 2.59, lower than 2.69. Again, it's biased toward the null as predicted. The last example, we're still doing non-differential. However, from the non-exposed عم حطهم بالexposed. So عم شيل من تحت من هون عم حطهم فوق. قد ايه عم شيل من تحت؟ 12%. So you remove 12% from 180, you put it up. 12% from 550, you put it up. By doing so, you get these numbers. And then you calculate the odds ratio, and sure enough, the odds ratio is again biased towards the null. Yani again, it's lower than 2.34. هلا, why is this important to point out that non-differential misclassification points out bias towards the null? لأنه if for some reason you have reasons that you may have done some misclassification, you may have done some errors in terms of classifying your outcome or your exposure, as long as you can defend and saying that your error was done non-differentially, that would mean that the measures of association you calculated has been biased towards the null. معناتها if you find an association, that association will still stand if you remove the misclassification. So مثلا in this example إذا أنا I run this study وطلع معي ال odds ratio 2.34 وإجا حدا قال لي عم تعمل misclassification, my answer would be okay, but my misclassification was non-differential, meaning that if I was able somehow to fix my misclassification, my odds ratio would actually be stronger. So me reporting this odds ratio of 2.34, I'm being conservative in my odds ratio. My odds ratio could be even stronger. So I wouldn't worry too much about changing the interpretation of my findings. My findings will still remain in the same direction. Okay, هذا if you find an association, if طلع معكم odds ratio showing an association. Okay. So all these examples, I showed you all possible examples of non-differential misclassification. What about differential misclassification? I'm going to show you one example just to illustrate the idea. I'm going to do a مش non-differential, I'm sorry, it's a differential misclassification with regard to the outcome. لكن حأغلط بالoutcome، حشيل cases حطهم بالcontrols. However, not at the same rate, not at the same rate in the case in the exposed and the non-exposed. يعني in the exposed حشيل 10% من الcases حطهم controls. However, in the non-exposed حشيل 25% حطهم in the control. So غلطي in terms of the diagnosis is related to the exposure. And therefore, I'm doing a differential misclassification. So when I did that, so I have 10% and 25%. Again, it's based on formula. So you can change actually these values if you want once you have this on Blackboard. But I picked 10% and 25%. So in the example, when you have differential misclassification, the bias could be either towards the null or away from the null. It depends on the situation. The situation I simulated, your odds ratio actually is biased away from the null. يعني هو the real one is 2.69. It appeared to be 3.29. It appeared to be even stronger, which is not the case. Alright, so let's go back to the lecture. لكن حكينا على misclassification. Let's see what happens in the article. Is there any discussion of biases in the article? And what is the chance of the following bias: selection, non-response, recall, and misclassification? And نشوف what they talk about in the article. So in the article they say, thereby detecting the potential effect of diagnostic surveillance bias among NSAID users. Maybe I need to read. So for confounding, in 4 secondary analyses, we restricted cases to patients with AFib or flutter who had their diagnosis listed as deferred diagnosis in the discharge summary, thereby detecting the potential effect of diagnostic surveillance bias among NSAIDs. So one of the potential bias is surveillance bias, which we did not address. However, the authors in this article decided to address it, and the point is they're doing a good job, really. They're working hard on addressing all problems. كمان, finally, using a rule-out approach, we estimated how strongly a single unmeasured binary confounder would be to be associated with the use of NSAID and AFib or flutter to fully explain our finding. So كمان, they're doing more things to address كل المشاكل possible. However, the interesting thing is the last piece, because that relates to misclassification. Data in the prescription database are virtually complete, although we had to use prescription data as a proxy for actual use of NSAID. يعني عم يقولوا نحن ما عرفنا إذا they actually used it or not. We used prescription, whether they were prescribed or not. لأن someone may be prescribed ما ياخد الدواء صح? We did not base drug exposure information on written prescription, but on actual dispensing on pharmacy. So we're looking at prescription, بس مش إذا prescribed ولا لا، إذا صار في dispensing ولا لا، which كمان ممكن حدا to be described ويروح ياخد الدواء من عند الفارماسيست and end up not taking it. يعني في مشكلة ممكن بالاكسبوجر، ممكن حدا بالاكسبوجر انت مفكر عم ياخد الدواء هو in fact ما عم ياخد الدواء. But listen what they say. Requirement of co-payment increases the likelihood of compliance. We lacked information on over-the-counter use of low-dose ibuprofen, which accounted for 30% of total ibuprofen sales and 50% of total NSAID sales during the study period. So, ibuprofen ما قدروا يلقطوا. So ممكن حدا يكون عم ياخد ibuprofen وهن ما معهم خبره. Which that lead to misclassification. You might misclassify somebody as not exposed مع إنه exposed. This هون بقى the important thing. This misclassification of drug exposure would mostly likely have been non-differentially and thus would have biased the effect estimate towards the null. أنا صار لي ساعة عم بشرح لكم misclassification and non-differential towards the null. So this is exactly what they're saying in this article. They're saying that if we missed people taking ibuprofen, so if we missed people in terms of their exposure status, يعني في ناس كان لازم يكونوا exposed وأنه نحن حطيناهم إنه non-exposed، هيدا الغلط is non-differential. يعني it happened equally in the cases and the non-cases, and therefore if our measures of association, if our odds ratio has been biased, it has been biased towards the null. بما أنه we did find an association, even if we fix that problem, even if we, for some reason فينا نلاقي اللي كانوا عم ياخدوا ibuprofen ونرجع نحطهم in the exposure group, all that would do, it will make our association even stronger, and therefore our conclusion would stand. So therefore, to the extent such misclassification occurred, our effect estimates are underestimated. Okay. All right, so finally, this lecture ends up with a table that lists the major strengths and limitations of case control. Again, some pointers here about case control studies. And finally, you've seen this where it's like a graphical representation of the case control studies. So that concludes the case control study for this lecture. Thank you for your time.